Hello and welcome to This is a Brain on Drugs Psychiatry podcast. I'm the punk rock psychiatrist, and this is part 2 of our first episode on Introduction to Depression. We're going to cover this depression episodes before we get into the medications. On this half, I'm going to talk mostly about assessing and diagnosing depression, and I think you're really going to enjoy this. Thanks for joining us, and let's get started. So I want to go into diagnosis and assessment of depression next. So I think most people are probably familiar with the DSM-5, the Diagnostic Statistical Manual, number 5. It came out around 2013. I think I was a resident when it came out, but the symptoms of major depressive disorder are virtually unchanged from the previous manual. So in a nutshell, to qualify for having major depressive disorder under the diagnosis, and I really take the DSM with a grain of salt. It is so subjective. I mean, you could argue that, oh, do they have this symptom or do they not? Or, oh, they have this cluster, and everybody has a different cluster of symptoms. And I think a lot of patients get really hung up on, do I have major depressive disorder? Do I have MDD? Stuff like that. And to me, that's less important. What's more important is what's not going right for you. What is and what's causing it? Can we find the cause of your ailment? It might be sleep. It might be a medical issue. It might be a situational issue, right? Whether you have this diagnosis, that doesn't condemn you to anything. And I think people like to have the label. I don't think the label is that helpful. I also don't think that, pretty much everything in the DSM are syndromes. And what are syndromes? They're clusters of symptoms that generally seem to be related to one thing or another, and we class them this way, and it basically means we don't know what it is. As we've kind of talked about the pathophysiology of depression, there's half a dozen, dozens of things that could make it more likely or increase the risk, or be for one person versus another. And to just kind of say, oh, you've got 5 out of these 9 symptoms, therefore you have major depressive disorder, from an insurance standpoint and getting things paid for and getting meds paid for and getting services paid for, unfortunately that's the way our health system works. I don't really agree with that. I don't like it. As if you listen to the first episode, you find out I practiced my entire career in the Navy. I wasn't beholden into this stuff. I didn't have to, justify the diagnosis to give the meds and things like that. And, a lot of you probably out there, oh man, I'm jealous that, you didn't have to deal with that. And it was great. It's great to not have to, basically try and fit somebody into a box that they don't necessarily neatly fit into. And so that's my soapbox on the DSM. But regardless, it's something, if you're a student, you definitely need to know this stuff. If you're taking a test, you definitely need to know this stuff. And if you're a new learner and you don't know anything about this, it's important to have some sort of, basis of, what is this, right? And if we're doing research and we're comparing research from one country to another and one school, academic institution to another, we've got to have some sort of common language that we can be like, okay, this is how you define depression and we define it the same way, so that we can kind of compare results and things. So the DSM is kind of a necessary evil as far as I see it. Like, we need it. It has its place. But when you're actually out there practicing mental health and you're actually treating patients and you're actually doing this and this stuff and you've been doing it for a long time, this stuff is really not that important at all. To kind of get to a point where you know what you're doing, and when you're reading the scientific literature and to kind of know what they're talking about, you need to know this information. But when I have a patient sitting in front of me, I'm not thinking, oh my gosh, what's the diagnosis? And, I'm thinking, what's going on with this person? What symptoms are they having? Is there a medication that I think that might, get in between that to solve that symptom, to help with that? Or is there something that's not a medication? Is it better sleep? Is it something else? I, I don't want to be like, okay, oh, you have this, and because you have this is the first line treatment, and this is what I'm going to give you, and if this doesn't work, I'm going to do this. This is not how I practice. A lot of people do practice this way, and that's part of the reason why I'm doing the podcast, is because I don't think that's a good way to practice. I don't think that's the most effective way to treat patients. I think you're checking boxes, and you're getting done at the end of the day, and you're help on average you're probably helping a lot of people, but are you doing the greatest good? I don't know. My personal opinion would be no. My personal opinion is get to know that person, find out everything about them, really dig down, figure out what's going on, and figure out what you think fits for this particular person. Because if that's not what we were what I think we need to do, I wouldn't need to do this podcast, because you could just like take out your checklist, go down the checklist, check off all the little symptoms that they had, and then go down your little algorithm and find, oh, I'm going to go with this one, and then this one, and then this one. Oh, none of that worked. I guess I've run out of choices, or I'm just going to keep adding things on. And a machine can do that. AI can do that. A monkey can do that. That's that's not the beautiful art of mental health and psychiatric practice that I want to convey in this podcast. And that's where we're going to get different. But at the same time, I want to make sure everyone listening out there knows what the DSM criteria are. So I guess I said I was going to go off my soapbox, and I didn't. And I'll probably jump back on it over and over and over throughout this podcast, because this is something I feel very passionately about, is this obsession with algorithms and checklists and things like that, which I think are a bunch of crap. So with that, what does the DSM-5 say? So you have to have 5 of the following symptoms on most days within 2 weeks. And you one of those symptoms must be a depressed or irritable mood nearly all day, occurring most days, or anhedonia. Anhedonia means that you're not enjoying things that you usually would enjoy, had enjoyed in the past. Maybe you like to play guitar, now you don't feel like playing guitar. You like to play soccer, you don't want to play soccer anymore. You enjoyed spending time with your family, and it just doesn't do that much for you. That's anhedonia. Okay. So you have to be either depressed mood or anhedonia. And then we need a total of 5 out of all these symptoms: depressed mood, anhedonia, weight loss or gain, difficulty sleeping, too much sleeping, um, not feeling tired, fatigue, not a lot of energy, having difficulty concentrating, um, having low self-esteem, feeling guilty, or just like you're not good enough and you've messed up and you've caused problems for other people. Um, Something we call psychomotor agitation or retardation. And essentially all that means is either you're like really jittery and like moving really fast and like can't stop moving and thing and shaking, or you're just like really slow, and somebody asks you a question and you take a really long time. You think for like 20 seconds and then you give a very slow response. That would be psychomotor retardation. So could be one of those two things. And then recurrent thoughts of death or suicide, whether that is you intend on hurting yourself, or you just kind of think, I'd like to hurt myself, I wish I were dead, I'm not going to do it, but I have these thoughts of not wanting to be around. So just anything kind of in that kind of suicidal thinking. That doesn't necessarily mean you are suicidal or you're going to commit suicide. um, it could mean that, but it could just mean that you kind of fantasize about it, or think about those sort of things. So, and I don't think it's a bad idea to say that these are symptoms of someone who is depressed. So I don't want to totally say that the DSM is total garbage, but to say that it must be during this period of time and this number of symptoms, and oh, you don't quite meet this one or that one, and therefore you don't qualify for getting a certain treatment or that or the other. Let's not split hairs. I take a general impression. Is this an anxious person? Is this a depressed person? Is this a person that can't concentrate or focus? Is this a person who is kind of not in touch with reality? Is this a person that's like wound up too tightly? Is this a person who, what is kind of popping out to me? And I don't necessarily need them to fit this exact definition before I'm going to give them a treatment that would be for it. So, but that is how we define it. So, and then those symptoms, right? We've listed the symptoms. And so now not only must you have these symptoms, 5 of those symptoms, it also has to cause distress or functional impairment. And that's either in work, school, or socially. So, I've had patients come to me, for example, saying, "I only sleep 3 hours a night," and I thought I should come see someone about it. And I said, "Well, does it bother you?" Because it doesn't seem like it bothers you. "Oh, no, no, I'm fine." Are you awake? Are you functioning? Are you having any problem? Is this a change? You go through all this stuff, and they're like, "No, I'm great. I'm fine. I just thought it was bad that I only sleep 3 hours a night." And I'm like, "Well, if it doesn't impact your functioning, then you don't have insomnia. You're getting the amount of sleep that you need. And so someone might have those symptoms and, you know, they don't feel it doesn't bother them. It's I'm not in distress. And I mean, I think it would be hard to have all five of those and it not cause that for in depression. But I mean, it may not. They may be like, no, it doesn't bother me. This is the life I want to live. I have a job. I'm able to feed myself. I have a place to stay. I have the number of friends I want to have. Maybe that's none. You know, that's not a disorder. If it's not causing any functional impairment and it's not bothering you, then that's not a disorder. And that's the case with any of the diagnoses that we're going to talk about throughout this podcast. It has to cause some sort of problem for you. And if you're not bothered and you're not having some sort of, and you may say, oh, the fact that they have no friends or they're not married is a problem, but if it's not if it's not impacting your ability to basically feed, clothe, and house yourself, and and affect your mood and you being distressed, then it's not really a problem. So it's important to qualify that, because people come in and say, hey, I read about this and I have all this stuff, but I feel fine. It's like, okay, then I'll reassure you. I'm not going to be like, oh, you're actually depressed and you don't know you're depressed. That kind of stuff irritates me. Where like, and I've had patients where like they've told me that their doctors have told them things like that. Of, well, he said I had this because I told him all these symptoms, and he said you have this, and it's like, yeah, but you don't. It's not bothering you. It's not impacting your ability to do the things that you want to do and need to do to stay alive and function as a human being. Then it's not a problem. And I'm not going to shove some treatment that's costing the system money, costing you money, causing adverse effects when you don't need it. So that's actually, I think when people talk about what the diagnosis of depression is or any diagnosis, they often skip over that one, like, oh, yeah, yeah, whatever, functional impairment. I think that's huge, right? I think it's huge if somebody doesn't, if that's not causing them issues, right? That's very important to have any of these diagnoses. And then moving on. So the symptoms can't be better explained by a medical condition or effects of a substance. So if you're having this because you're taking a depressant like alcohol or heroin, then major depression is maybe not your problem. Now, did you have the depression before you start using the heroin? Right? Like, or were you like doing great and you just, you know, got on opiates from the doctor, and that we all know this whole story, and then you get addicted to them and you're on the heroin and now you're depressed. And so that's where we have to tease this out, like the chicken or the egg, what came first? If you were fine and then you used a substance and then you started feeling depressed, we need to get you off that substance. This is not major depressive disorder. This is substance use disorder, and only that, right? But in many cases, people use the substance because they had the depression to begin with. And so, just because you're using a substance doesn't mean you can't have this. But that's why we say symptoms are not better explained by a substance or another medical condition. So, say you've got a medical condition that we could actually fix that medical problem and you're not going to be depressed anymore. And we're going to list some of those here in a second. Um, that's not major depressive disorder. It's the other medical problem. All right. And then also, the symptoms are not better explained by a psychotic disorder. So if you are psychotic and you have a primary psychotic disorder, so you can actually have depression with psychosis, or you can have psychosis and then depression on top of that. You can have something called schizoaffective disorder, which is a mood disorder like depression with schizophrenia. It's very complicated. And once again, this is like splitting hairs in the DSM. But if your depression is caused by a psychotic disorder, that we can fix the psychotic disorder, and then you're not depressed anymore, then you didn't have a depressive, you didn't have a depressive disorder. You had the psychotic disorder. But of course, you could have both, right? And that's where the years and years of training that I've had and other mental health folks out there have had to help us figure out what those differences are. And then also the last one, that these symptoms cannot be better explained by a manic or hypomanic episode. And we'll get into that when we talk about bipolar disorder. So basically, you have the up mood and the down mood. The down mood's the depression. If you have that hypomanic or that manic episode, you don't have major depressive disorder, you have bipolar disorder. So you can't have bipolar disorder and major depressive disorder. You can't have both of those. It's one or the other. So if you've got the mania or the hypomania, then it's not major depressive disorder. So, but we'll talk about that when we get to those episodes. So I mentioned before that there can be medical causes of depressive symptoms. So what might those be? So you could have a thyroid problem, not enough thyroid hormone, too much thyroid hormone. Both of them can cause depression. Diabetes can cause depression. So like unmanaged diabetes, right? Diabetes is a disease of basically insulin sensitivity, resistance, right? You're resistant to insulin, you got too much glucose, sugar molecules flying around your body, and having too much glucose causes damage to end organs, blood vessels, that includes the brain, that can cause depression. So unmanaged diabetes can cause depressive symptoms. Parkinson's, actually 50 to 75% of Parkinson's. And I mean, what's Parkinson's? We're losing dopamine. I mean, you lose dopamine first in more of the movement type stuff, but then you start losing dopamine in other areas as well. And I'll probably cover Parkinson's later, but you're losing those chemicals. Now, here's where we're talking about someone with actually a chemical imbalance. We're actually losing those chemicals because the Parkinson's disease is destroying them. So, epilepsy, actually 30%, I have this statistic, 30% of people with epilepsy, this is a disorder where people have a lot of seizures, have a suicide attempt. 30% suicide attempt, very high. Multiple sclerosis, 25 to 30% of those folks have depression. And that's a disorder of nerves. So we're losing the conductive substance, the myelin sheaths on the nerve cells, where that's going away. So our nerves aren't conducting the way that they're supposed to. And of course, nerves are involved in our mood. We talked about that before. Alzheimer's. Alzheimer's is the loss of brain mass. So we're losing brain. Our brain with Alzheimer's, your brain is shrinking. Your brain is dying, and so of course that can affect the mood parts of our brain as well. We'll go into Alzheimer's in another episode as well, and then cardiovascular stuff. So cardiovascular accidents, which are like strokes, myocardial infarctions, heart attacks, chronic CHF. It's an enlarged heart. CAD, that's coronary artery disease. So all these kind of, I talked about those studies at the beginning of this episode. And then HIV AIDS can cause depression, cancer, fibromyalgia and pain disorders, rheumatoid arthritis, lupus. I mean, lupus is like system wide. We've got inflammation all over the place. I actually had a patient that she primarily came in with like a bipolar presentation. And the more I was kind of like getting to know her, I started to think this patient has lupus. And she had tests run earlier that were negative, and then I reran them, and it turned out she did have lupus, and it presented with bipolar disorder symptoms. So lupus, it you have inflammation all over your body. It harms like all your organs. It's a really nasty disease. Um, Going on, adrenal disorders. So that's where cortisol is in your adrenal glands. Those are the glands on top of your kidneys. Vitamin mineral deficiencies. So like basically malnutrition, right? You don't have enough B12 or B6, B1, folate, D, C, magnesium, zinc, like all sorts of things. If you're malnutritioned, those vitamins and minerals are cofactors. They're used in chemical processes in your body, and your brain won't work correctly if it doesn't have these in there. And so depression could be a consequence of that. And then anemia. So, that means your blood is not, you don't have enough oxygen circulating throughout your body. So your tissues are not getting perfused with the oxygen that they need. And can and oxygen is used to run the chemical reactions in your cells to produce proteins and do all the things that cells do. And so that can affect your brain as well. Lyme disease, testosterone deficiency, Wilson's disease, that's a really rare disorder we'll touch on in another episode. And there are others. And so these are all things that could be causing depression that are not major depressive disorder. And then I want to talk about medications. Okay. Medications that cause, so like medical disorders, that's something that's kind of outside of your control, for the most part. Medications are, that's, something that you're taking from your doctor to treat something else, maybe, that's causing depression. So there's actually, the FDA has these thing called black box warnings, but they're actually called like boxed warnings, but we call them black box warnings because there's a little black box written around it on the package insert of the medication. So if you take a medication, especially if you take an antidepressant, look in there. You'll see the black box and it will say increased risk of suicidality in patients up to the age of 25. So that warning was actually put on antidepressants in 2004. We'll get into that later. I'm going to go into details on that. But how ironic that medications that fix depression can actually cause depression. And, I get patients that are taking medications, and I often will stop medications because I think you're worse since you started taking this. I think somebody put you on this with good intentions. It caused the opposite reaction, and let's get rid of it and maybe use a different type of medication. But first, let's see, maybe are you going to get better when we stop this? It's like I wasn't having suicidal thoughts before I started taking this medication. I mean, I was depressed, but so that warning was placed in 2004. And it also includes not just antidepressants, but all the antipsychotic medications that are approved for use in depression. We will talk about that in this lecture series on antidepressants. We will talk about the antipsychotics that are used for depression. VMAT2 inhibitors, we'll talk about that in our antipsychotics lecture that treats tardive dyskinesia. Actually, only the VMAT2 inhibitors that are specifically for Huntington's disease and not for tardive dyskinesia have the warning of increased suicidality. That warning happened in 2008. Mefloquine, that is an antimalarial drug. 2013, I actually had a patient that had taken mefloquine. He was in the military. It was something, when you deploy out in the world and you go somewhere where malaria is, going on, they would give folks this medication to prevent them from getting malaria because malaria sucks. You really do not want malaria. And so, but this particular one, years later, it, there's thought that this actually can cause some damage in the brain. Anyone out there that took mefloquine feeling depressed, that might be the reason. You don't even have to be taking it now. I mean, typically with the antidepressants, antipsychotics, we stop them, we don't get the depression anymore. But the mefloquine, in this one case, I actually had this one patient, and he was quite convinced, and he had all this documentation, and we reviewed, and I thought it was reasonable. I gave him Zoloft. I gave him sertraline, and it seemed to help. But there was a thought that mefloquine may have caused his depression. And then the most recent medication that was black box warning added for suicidality is montelukast. Okay, a medication that is used for asthma and other breathing disorders like COPD, um, things like that. So montelukast the warning was added. That's singular for those of you that are more familiar with that. So, that's a pretty common med out there. If you're on singular and you're like, hey, I'm depressed and I don't know what's going on. And hey, that actually did start around the same time I started taking that Singulair. Go to your doctor, ask them to take you off the Singulair and try something else. Don't just stop it though. I don't want you to have a asthma attack and die. But yeah, that medication could be the reason, and that's why we don't just add meds to people. I don't just give This is why I don't just give people an SSRI antidepressant because they're feeling depressed, because it could be that they're taking a medication that's causing it, or a million other things. All right. Varenicline, Chantix, was used for smoking cessation. It once had a black box warning for depression, removed. They found that to be unsubstantiated. We will talk more about Chantix. I really like Chantix, Varenicline. It's an excellent medication to stop smoking. I love it. Um, it can cause some mood issues, but you don't take it forever. So if I can get you off that tobacco, I would really love to see that happen. Um, and if we can get through it, if you're having some side effects, you only need to take it for a few months, maybe. But that warning was actually uh, rescinded about 10 years ago or so. Um, and then those are the ones that had the boxed warnings, but let's go through. There's a ton. If you're looking at the slide, you probably already read them all and you're like, okay, stop talking, I've read all the meds. But so other leukotriene inhibitors, so the montelukast singular leukotriene inhibitor. Others, zafirlocast, xyluton. I have no experience with these, but they they don't have the boxed warning, but they have a similar mechanism of action, so they could potentially cause depressive symptoms. Antipsychotics I already mentioned. Um, anything Basically anything that's messing with the brain and the functioning of the brain, gets anything that gets into the brain could potentially cause depression. And that's what you're going to see from this list. Stuff that gets through the blood brain barrier, messes with what's going on up here. All right. Antipsychotics, benzodiazepines. Those are like your Xanax type of medications, your calm down medications, your tranquilizers. Naltrexone, we use that for alcohol cessation, amongst other things. The meds that we use to treat Parkinson's. So basically, meds that we use to treat brain disorders, because they get in the brain, they can cause depression. That doesn't, hey, I'm not saying stop taking these, right? I'm saying that these are potential causes. Anti-epileptic drugs, but it may be a reason to use a different one. If you notice, hey, since I started on this medication to treat this disorder I have, right, we could switch to a different med. Okay, we could go to our doctor, not stop the med on our own. We don't do that. We go to our doctor, we say, hey, I have this, I listen to this podcast, this guy sounds like he knows what he's talking about, and he said, hey, this med could cause this. And just because it could and you have it doesn't mean that the med did cause it. And that's why we go to our doctor, to try and, have them sort it out. I'm not your doctor. I have to remind people of that over and over. I don't I'm giving you information. I am not telling you what to do. Take this information, and if you're a patient, use it to be more educated and talk to your doctor about things. And if you're a doctor, use it to better treat your patients. Okay? So anti-epileptic drugs, oral contraceptives, H2 blockers, those are meds that we use for acid reflux disorders. GLP-1s, oh my goodness, the medications that help us lose weight can actually cause depression. And I've never seen this. This is something that's reported. I've added it to the list. Clonidine, that's an alpha 2 agonist. Is a heart medication, amongst other things. Beta blockers, these are also heart medications. Methyl dopa, that's an antihypertensive medication. Corticosteroids, anti anti-inflammatory medication. Interferon alpha, something we use to treat hepatitis. Indomethacin, that's a NSAID like ibuprofen, a non-steroidal anti-inflammatory drug. Analgesics, so opioids in particular, and opioid-like medications like tramadol. Anti-neoplastics, those are like chemotherapy drugs for cancer treatment. Isotretinoin, um, that's a medication used for acne. Oseltamivir, that's an antiviral. Zanamivir, antiviral. Antiretrovirals, which are medications we use to treat HIV infection. Ciprofloxacin is an antibiotic. Roflumilast, not even sure what that is. That one, I I think is a breathing type of medication. I'm sorry, that is not a medication I see very often. All right. Well, sorry this episode's so long. I want to get through the rest of the slides on the intro so we can get into the meds at the next episode. So feel free to stop and come back to this. So, next, how do we do the patient assessment, right? So we evaluate the target symptoms of depression. We already talked what those were. That was our SIGI caps. If you've been to med school or you're a resident or whatever, those are the DSM criteria: depressed mood, sleep, interest, guilt, energy, concentration, appetite, psychomotor, agitation, retardation, suicidal thinking. Right. So all those symptoms of those DSM criteria, we want to assess those. Which of these, which of these symptoms do you have? What we want to see what your particular issue is. That could help us figure out what treatment might be the best one for you. Another thing we can do when we do assessments, rating scales. So these are things like PHQ-2s and PHQ-9s. These are depression rating scales. The PHQ-9 basically lists those 9 symptoms and asks the patient like how much each one of those bothers them on like a scale of 1 to 5, 1 to 3 actually. And so your max score would be a 27, meaning that like it bothers you all the time, each symptom, right? And a 0 would, or no, there is no 0. It's, I believe, maybe there is yes, 0. 0 would be none, no impairment. All right, and there are other scales out there, and you know there's pluses and minuses to these scales. Patients are not always honest on a scale. In my experience, patients hate filling them out. They don't think that seriously about them, and they don't necessarily give you great information. And so some patients are going to put good information. Some people are going to over embellish their symptoms. They're going to say, I want to appear really sick on this thing. And it's like, then you can't even tell that they're getting better because they're like saying their symptoms are super high no matter what. And then you got other patients that they look terrible and they're doing terrible, but they've got a really low score. And so I think there's a place for these, particularly in research, and maybe like on one patient to kind of see, are their numbers going up or down? And to kind of maybe, justify maybe doing something with your program that you're doing at your clinic. But how good is this? I would prefer to just ask the patient myself and get the information. I know that can take time, but you're going to get better information. You're just going to get better information. And in a new appointment, you should have more time where you can go through all this, and then you're in subsequent appointments, you're asking about changes. Okay. So what else are we assessing? The comorbidities, their past medical history. So we want to know about all their other medical problems. We want to know about their past psychiatric stuff. What have they been diagnosed with? What meds have they taken? We want to know all that information. Do they have family members that have some mental health stuff going on? What meds are they taking now? Which ones did they used to take? Why aren't they taking them anymore? Just like everything about, like, I want to know when you took it, how long you took it, did it help? Why'd you stop? What happened when you took it? Because I could get you back on that same med. If you got a family member on a med, I can get you on that med, right? If you hated one, I don't want to repeat the same mistake, right? So we want to know that whole med history. And then labs. I don't get a lot of labs for depression. I know a lot of people do. I'm not a huge fan of this. I don't like sticking people. I just don't. Unless it's like absolutely necessary. I just don't think I'm going to learn that much. But in some cases, I pretty much, if you've got depression, there should probably be some thyroid function labs somewhere in there. Maybe you already had it done by your primary care doctor. If not, I might order that one. I'm also, I'm going to be thinking about, because what are the symptoms of thyroid issues? But that's one I might be a little more likely to get. But typically, patients have already had it, and I can see the results. A complete blood count. If you're suspecting like anemia, uh, symptoms, low iron, that would be utility in getting this lab. If malnutrition or alcoholism or they're on a very strict diet, like a really strict vegan diet where maybe they're not getting their B12. That would show up in a CBC, but you might want to get that B12 separately itself. um, a chemistry, there's not a whole lot from a this is a basic metabolic panel, just not a lot I'm going to get from this. I mean, calcium issues could cause depression, but like it's really uncommon, and they're probably going to have a lot of other symptoms of calcium going on. I've never ever picked up depression from a calcium issue in a patient who had a chemistry lab, either by me or anyone in their history. I was, oh, look, your calcium's, that's the reason. I've never seen it. Not saying it can't happen, but haven't seen it. Sodium, if you're taking a serotonin reuptake, any kind of serotonin reuptake inhibitor, that can cause low sodium. I'm not in the military, like my young, healthy population, really not concerned about this. In an elderly population, I'm going to be a little bit more concerned about that. So if I've got some older patients, some sicker patients, they probably, and if you're an older, sicker patient, you've already got these labs. So I'm going to probably want to look into that sodium to make sure my medication's not causing that problem in that population. It's not one that I saw a lot of in my career, but it's certainly a lot of them out there, and that would be a reason to be looking at that. Substances, urine drug screen, a variety of different labs, and we'll talk about this when we talk about alcohol for alcohol detection. You know, we might want to get a drug screen if we're suspicious of that. I'm sorry, I tend to trust patients. I feel like patients tend to tell me the truth if I'm honest and frank with them. I think they tend to be pretty honest. And if or I have a suspicion that they're not being, I'll order this stuff. Right. Um, so I certainly would. And then vitamin D, that to round out all the labs that could affect depression. um, Theoretically, and I've heard this, but I have never. I've seen so many patients with low vitamin D. I've never, ever, not one single time have I had a patient with low vitamin D repleted their vitamin D, and they weren't depressed anymore. I've never seen it. If somebody's seen it, comment down below. Guys, I've never. I'm curious. Does this happen? Are there people out there with low vitamin Ds that are corrected and their depression goes away? Please let me know. I've never seen it. So I tend not to really mess with this lab because I just don't see the utility. And, I don't see that patients, if even if I do find it's low, that it actually helps them. I'm sure it's out there, but I just haven't seen it. So those are some of the labs. I tend to check none of these. Um, I I don't go based on, oh, this person's depressed, therefore I'm getting all these labs. No, I would say, what else is going on with them? What are their other symptoms? And we can get into that in another episode. I just want to kind of briefly go through things here. And then suicidality. Of course, I will assess for that. And when we're doing a suicide assessment, we're not going to go into a big suicide assessment in this episode. I'm just going to go kind of run through these. um, Presence of suicidal, homicidal ideation, intent, or plan. I want to look into this. I want to know about that for sure. Have they ever tried to kill themselves before? And I use the word kill yourself. I don't like this hurt yourself. If you get that information, you need to qualify. Is Were you intending to die, or what were you intending to do? Not that it's not serious, but it's more serious if you intended to die. And I think a lot of people just kind of they tiptoe around these issues. Have you ever had thoughts, or have you ever done this? And then all of a sudden somebody's been hospitalized that didn't need to be. I see it all the time. And then I get patients that are like, oh my gosh, I don't want to talk to you because you're going to hospitalize me. And I'm like, I'm not going to hospitalize you unless you and I are both worried that you're going to die. Like we need to be concerned here that you need your safety preserved. I'm not just going to be like, oh, you said something that ticked me off, or not ticked me off, but like, you know, piqued my interest, and I'm not going to get any further details, right? We could do a whole episode on this. But yeah, suicide assessment is a huge part of a psychiatrist's job, and not always done well. Not always done well. So I want to know details. What did you do? What did you physically do? What did you think was going to happen? What are you concerned that you would actually take an action that would end your life? And do they, and sometimes they don't know. And that's information. The fact that you don't know is information. But I don't want to stop asking questions. I want to know all the information. I want to know what is going on in your head when it comes to your thoughts of suicide. Okay? Um once again, like I said, we could cover that another time. But access to lethal means, so like if someone has access to a weapon, that increases their risk that they're actually going to use it. If they're if they're not having suicidal thoughts in the first place, I'm not concerned that they have the weapon. But if they're having the thoughts and they have access to the weapon and they're thinking about they might use it, hey, that's the concern. So just having a gun, that's not, I'm not going to go crazy on you. If you have severe anxiety, panic attacks, agitation, impulsivity, in addition to some suicidal thoughts, that increases your risk. Psychotic symptoms, especially if you have voices telling you to kill yourself, of course, that's a huge risk. If you had a history of psychiatric diagnoses, alcohol or substance abuse, family history, recent exposure to suicide, someone in your family's harmed themselves or someone close to you recently, or there's been an anniversary of that happening in someone who's thinking about suicide, that can increase their risk. And that they don't have any protective factors. There's nothing stopping them from killing themselves, essentially. So that's a basic suicide assessment, but there's so much more to it. I don't want to leave it just at that, but just to say that we're going to do a suicide assessment in people that have depressive symptoms. So let's talk about treatments. All right. I actually think that this would be, well, let's stop here. We've gone an hour and a half. I want to cut this short now. We'll go through treatment course. We'll talk about non-med treatments, and then we'll kind of get into the beginning stages of treatments on our next episode. So I want to thank you so much for listening for the whole hour and a half. I hope you enjoyed this. And, if you came here looking for information on meds and you're like, oh my gosh, this guy talked for an hour and a half and he didn't talk about meds at all, you know, I'm building up to it. We're close. And then once we get through the next few pieces of information, we're going to go through SSRIs, SNRIs, NDRIs, the new meds that are out there, glutamate stuff. And we're going to dig in deep. That's what this is about. I'm going to give you all the information, and I'm going to give you, like, I don't want this to be like I'm just reading off of like a expert opinion database, like an UpToDate or a Micromedics or something like that. I want this to feel like a real conversation that we're having, and you're sitting in the car and you're listening to this and you're getting these details, and I'm telling you, like, this is when I would use this drug and this is when I wouldn't, because this is a big thing that I want this podcast to be about. Is I don't want this to just be a general discussion about the topic. I want you to actually know what's the difference between this one and this one and this one and this one. And I want you to see those like side by side. And I want you to be like, oh, that's, how these kind of differ from each other. And that will help you hopefully pick the one that works for the patient better, and make a better choice. And that's really what we want to do here with the podcast. I want to help you know, first, should I even give this person a med? That's first. And second, what, which one to pick, and how do I know? Is it just random? Like, no, I want you to make an educated guess, and I want you to make that educated guess based off the information that we're going to hear about in the podcast. So once again, thank you so much. This is, I think the slideshow worked this time. I'm pretty excited. Um, the slides, everything's going to go up on my webpage, punkrockpsychiatrist.com. Instagram, I'm going to make announcements on Instagram. That's at punk_rock_psychiatrist. My YouTube channel, the same name. We're gonna get into the meds probably next. I might make a short episode next and then hit the meds after that. And yeah, I'm excited. I hope you guys are excited to hear about all this stuff and learn, and it's going to be great. So come back next time and we will get on with antidepressants.